As far as peripheral vestibular orders go, BPPV is by far the most commonly seen peripheral disorder in clinics. BPPV stands for benign paroxysmal positional vertigo. Benign meaning non-cancerous, paroxysmal meaning sudden onset, positional means it comes on with a certain positional head change, and vertigo is an uncontrolled feeling of dizziness and spinning in the room. When it comes to these, this is when the crystals, the otoconia, and your semicircular canals get knocked out of place, go into the semicircular canals, which disrupts the endolymph fluid flow, therefore sending abnormal signals to the brain to make you feel like the room is spinning. Out of those three semicircular canals, the horizontal, the anterior, and the posterior canal is the most commonly seen BPPV. There are two different types of BPPV, canalithiasis and cupulolithiasis. Canalithiasis is more common. That is when the loose debris gets stuck in the semicircular canals when they're supposed to be down here. The cupulolithiasis is down in the cupula, so it's dislodged, however, it's still stuck in this area. For horizontal canal BPPV only, there are two types of directions that the nystagmus can twitch in the horizontal direction. One is called geotropic, and the other is called apogeotropic. Geotropic means that the nystagmus is going to be towards the earth. So if your patient is sidelined in this direction, their nystagmus is going to be in a downward direction towards the earth. For apogeotropic nystagmus is going to beat away from the earth. So when your patient is sidelined like so, their nystagmus is going to go in an upbeat direction away from the earth. So since posterior semicircular canal BPPV is the most common type of BPPV, we will focus on the signs and symptoms of that more. So as far as nystagmus goes, you're always going to see an upbeat and torsional nystagmus. So what that means is if you're looking at your patient, this is your patient's right and their patient's left, it's going to go in an upbeat, meaning towards the ceiling, and torsional. So it's going to turn like that. You can name it based on the torsion. For example, drawn here, the torsion is going to the left or in a clockwise direction. So you would call that left torsional, or you can document it as clockwise torsion. Now, if the torsion is going towards the patient's right, you would call that right torsional nystagmus, or counterclockwise, because if you're looking at a clock face, this is going in a counterclockwise direction. So counterclockwise is right torsional. The rotation is always going to be towards the affected side. When you're looking for nystagmus, there might be a 5 to 10 second latency, which means a 5-second delay after you put them in that positional rotation before the nystagmus starts to occur. Like I said, the nystagmus is always going to rotate towards the affected side. So for example, if you have them in a right head hanging position and you see the nystagmus rotating towards the patient's right, it would be a right posterior canal that is affected with the BPPV. To diagnose specifically posterior canal BPPV, the gold standard is the Dix-Hallpike exam. After you've confirmed this and you want to treat it, you will treat any of the BPPV disorders with canalith repositioning maneuvers. For posterior canal specifically, this will be the modified Epley maneuver, which is also the gold standard for treating posterior canal BPPV. For more specific information on how to complete these diagnostic tests and these canalith repositioning maneuvers, see the links below for my other videos on these tests and treatments.